After my first retirement in 1985 and some travels abroad to study single-payer universal health care in other nations, I did a stint of 2 years of rural health in underserved mountains west of Denver. That came about because I did some part-time teaching and precepting in family medicine at the medical school, working with residents in family practice. And an inquiry came in from the director of the Columbine Family Health Center in Black Hawk and in Netherlands, saying that they were having a tough time recruiting and retaining physicians at those sites. And they wondered if the Department of Family Medicine at the university would enter into an agreement to provide physician staffing for them. And so I and a nurse practitioner went to visit these 2 sites and make a recommendation as to whether they should or should not get involved with this opportunity. I was impressed with the commitment and the loyalty of the nurses and the staff at these 2 clinics and the great need. The clinic in Black Hawk was the only one in all of Gilpin County where a person could get medical care, and the one in Netherlands served all of the mountain district of Boulder County. And they had patients from the Continental Divide all the way down to the suburbs of Denver. The nearest physician was in Idaho Springs in private practice, and if patients did not have money to pay for his services or did not have private insurance, they were referred to the clinic in Black Hawk. So we had an extensive range of patients, 22,000 patients we served, and I thought this would be an excellent training experience for the residents in family medicine. They could commute daily to Black Hawk or to Netherlands and experience rural health without having to move a long distance to have that experience. So I recommended they take on the physician staffing, and I happened to be the first physician assigned to those 2 sites. I was medical director for 2 years, and the patients had a myriad of medical problems, as one would expect. My 2-year tenure began before the law was passed to allow casinos to be built. So the first year we had primarily local residents, people who enjoy the solitude of the mountains, very independent and tough individuals. Then the construction workers came in, converting the old dilapidated buildings to new buildings, and because of historic preservation, the facades had to be maintained while the old buildings were converted and upgraded for new purposes. And then the new mega casinos began to be built. And it was so the patient load included not only the locals, but also the construction workers, the road accidents, and of course the summer opera singers and orchestra and attendees of the operas. So we had patients from New York City to the gamblers that came by the busloads from the flatlands of our country in the Midwest to the locals who were acclimated to the altitude. The heartbreaking part of this experience was that only 10% of the patients we served were covered by Medicare or Medicaid. Only 20% had private insurance. 70% had no insurance. And these individuals would refuse to go to the emergency room because they did not want to lose their life savings or their homes because of medical bills, which were outrageously inflated. And they would wait until we unlocked the door on Monday morning to get the help they needed, even though they'd been sick and injured for days. Our clinics were open from 8 a.m. till 6 p.m. 5 days a week, and we suggested they go to an emergency room when we were not available. but they would not go to an emergency room, even in critical situations, because they were not willing to lose their financial resources, their life savings, and their homes. And it was heartbreaking. We had patients with cancer, with heart attacks, fractures, all sorts of injuries, and healthcare was literally not available except what we could do on site at those clinics. This just reinforced my commitment to work toward achieving universal, comprehensive, quality healthcare for everyone living in our state.